morning, everybody. I was asked to kick this off for you. I want to thank all of you for coming. I want to talk a little bit about what we expect. We've looked at a lot of models in the healthcare system. I spent a lot of time looking at the models that are out there. It is very clear we're going to see a surge, and that's going to come about 3 to 4 weeks from now. We would like to say that that's going to be deferred. The ability to defer that really is not possible. What social distancing gives us is to help flatten that so that we are not overwhelmed. As I look at this, a good outcome for this community would be 200% to 250% of our hospital capacity. I think that is a real optimistic look at this. As we look at the models, some of those models give us as much as a 500% overcapacity for hospitals. We'll know later this week as to how we're approaching that surge and what our doubling times are doing. But this is very real. So I want to talk to you a little bit about what the system has done for surge plans. You know,
I know you don't like it.
Can you all hear me?
This is for the recording.
That's for the recording. Damn it. So, insofar as surge planning, every single hospital has a surge plan. We were required by New York State to submit a surge plan to go to between 150 and 200% of capacity. And we break that down into 3 phases. The first phase has already been enacted, which is getting additional beds simply by reducing what doesn't need to be in the hospital on a urgent, emergent basis. So that was the cancellation of elective surgeries. Working hard to get patients out of the hospital. Moving some patients who, like chronic ventilator patients we've had in this hospital for years, we are down to 2 of those patients right now, and we're working hard to move those patients out. Phase 2 is looking for taking care of patients, our typical patients, in typical locations that we don't typically use for inpatients, okay? So, holding areas for the cath lab, PACU, moving resources and changing how we use units. And we concentrated a lot on that here because we know that this is one of the places that can ramp up ICU coverage. And so RGH, which has typically about 42 ICU beds, we've gone to a plan to go to 72, which we can turn on like that right now. And we have ventilators ventilators for all those beds, and we can do that tomorrow morning if we need to. We have a plan to go from that to up to 90 plus ICU beds. That plan goes into the PACU. It involves, in the absence of getting more ventilators, converting 20 of the 30 of our anesthesia machines to ventilators. We have an order that has gone in for General Electric, which was accepted on Friday, and General Electric has the supplies for us for 50 more ventilators. And we're working on sourcing more vents. So in the surge plan here, it's looking a lot about increasing ICU capacity. In the details of that, our phase 3 of that is going to a situation where we start putting patients in atypical locations. And every single one of our hospitals has a plan for doing similar things. The atypical spaces become our overflow places. If you're familiar with this hospital, it's the main conference room. It's the cafeteria. It's places that we can take care of patients. We've taken care of patients in those locations before, but it's tough to do. It requires us bringing oxygen tanks in. It brings us bringing suction machines in. The logistics become a little bit more challenging, but certainly in going to greater than 150% capacity, those are discussions we've had on how to do that. The system also is looking at working with the community to develop a surge hospital and how and where we can put in as many as 1,000 beds someplace else in this community. These are all the realities that we have to face and are working on right now and working on very aggressively so that we have the capacity to handle a surge of patients. Social distancing will blunt the peak of that, but it will not slow the fact that this is coming. all of you are doing a really phenomenal volunteer job here doing this. I really want to offer my profound thanks to you for this. This will be a challenge for all of us. And how we figure out how to take care of 500 patients by extending the expertise of every single person in this room is the challenge that we have. And what I've been amazed with is the number of people who've been willing to step up, the number of people that have put things together really quickly. James put this together in 5 days. And that gives me courage, that gives me optimism in that we will do this. Healthcare will look very different. We're going to be doing things very differently in the future in healthcare than we did last week, 2 weeks ago, 3 weeks ago. We're going to learn a tremendous amount, and we're going to learn a lot about ourselves. One final note is just to realize a little bit of the impact this will have on all of you, and it's having on all of you. Made the comment on a phone conference for folks on Monday morning that between the time I woke up at 5:15 in the morning and 10 o'clock when I was on the phone with folks, I had gone through a range of emotions, and I could see each one hitting. It was frustration, it was anger, it was sadness. All of those things are what we do in grieving, okay? We're grieving something that we're losing. As you deal with other people, and as you deal with people, you're going to see that in folks. Accept that. Know that. It'll help you deal with them. And that's what you need to make you strong and be able to get people to do what you need them to do. Because what we're really asking you to do is not just learn how to do this, but how to run larger teams of folks and direct them, and folks who may not typically be folks that are listening to you, that you're helping do the jobs they do. It's going to be APPs helping physicians do things that is out of their normal scope of practice. You are the ones that expand this and cascade this, and I thank all of you for being here. Have a good day, socially distance. You're going to do this, okay? And I can't tell whether the single person is smiling, so this is like the worst audience to talk to. Thank you all very much. You can always reach out to me if you have questions for me, recommendations. I'm happy to listen to everybody. Everybody knows that. So have a great day. I'll stop by and stick my head in occasionally. See you guys. Thank you.
Thank you, Dr. Casey. All set, yeah? Okay. All right. So first of all, thank you very much for coming. This is, like Dr. Casey says, these are unusual times. And so I got asked, tapped on the shoulder to do this on Thursday morning. And I was still working, so I worked until Sunday morning, and then sat down and started thinking to myself, how are we going to make this happen for you all? So, Tia, I imagine this is working. Let me see here. If it's not, then I'll use this. So the thing is that Tia has an amazing way of making things happen. So as we sort of talked a little bit about what we're going to put together, I said, well, we're going to do a little bit of a review course for folks. And for some people, it will be new stuff, and for some people, it will be like a lot of old stuff just coming back up again. So the theme, of course, is, this bio event. I mean, this mass casualty event that we're looking at. And we'll talk a little bit about that. And we'll try to make everything interesting for folks. This remote isn't working. So I'm going to try to just work. Okay, so I'm going to do a little bit of introduction first. Thanks, Tia. Introduction, just a little bit about me, just to tell you who I am. Written some books on materials that we've talked about here, and so, basically, I've been doing critical care since about 1992. That's when I finished my fellowship, which is longer than most people in this room were long before you were born. And so, unfortunately, I've had the opportunity to do some things. I do have ADD, and I do have ADHD, so what happens is on one side, I want to do so much. On the other side, I get very easily distracted, so you'll know a little bit about that as I get going here. That's the brutal truth about me. And I want to tell you that there's some amazing resources out there. We have taught these courses here before. They're through the Society of Critical Care Medicine, and one is the Fundamentals of Critical Care Support. We've done that about 6 times. I know there are many people in the room here who have helped me with that course in the past. You can get that course online. I think it's open access right now because of the crisis that's going on. And the other one is Fundamentals of Disaster Management. Okay, both are through the Society of Critical Care Medicine. When we did the Fundamentals of Disaster Management course, we did it at Unity, we did it in the auditorium. We used a lot of space because we had to go through a lot of the skill stations. And at that time, we had no idea that any of this would ever come to pass so that we would ever need it. Another really good resource is the Department of the Army, Department of Defense, has the AMRID course. They have 2 courses. One's AMRID, the other is AMRICID. I'm certified in both. AMRICID is basically chemical disasters. The other one's biological disasters. And you can take these courses now online as well. Okay, so they're open to the public. Thank you, Tia. And these are amazing resources, especially now. So think different. Okay, a lot of what we talk about today is going to be sort of non-traditional critical care. I mean, how do you provide critical care in a tent, right? You know, this is a little bit different paradigm than we've ever been used to. So we're going to explore some of these things. And I do have to thank the team. Okay, when I got tapped to do this, I looked and started talking to Tia. Tia said, "What do you need to have to make this happen?" And then when I walked in here this morning, and over the course of the weekend, we've talked a dozen times or so on the telephone. And I looked in here this morning, I couldn't believe it. Okay, we're almost ready to do patient 0 right here. So the fact is, Dr. Pinino, of course, Tia, Selma, and of course my faculty. My faculty is going to include Dr. Herman, who's with Palliative Care, and he volunteered. He called me on the weekend. He said, you know, I'd really like to talk about the moral distress and a little bit about the burnout feelings that folks get when they're taking care of these patients. I said, yeah, let's do it. Let's work in right after triage. And we're going to talk a little bit about triage this morning and go right into Dr. Herman's presentation on moral distress, which I think many of us are going to find, especially when you're taking care of these folks, and we maybe have to start thinking about rationing ventilators, you know, making big decisions and tough decisions about how we start doing these things. And of course, Kristen Stewart has been my PA for, I don't know, 10 years. She's a lead PA in the SICU. Taylor Hughes, one of our top nurses, and Sean Test, who's respiratory therapist extraordinaire, who's bailed me out of some pretty tough situations. And we're going to go through a lot of skill stations this afternoon. So afternoon is going to be skill station time. We've got a little bit here for everybody. We've got PIC lines, we've got intubations, we've got arterial catheters, we've got IO lines. We're going to show you all how to use an ultrasound to locate internal jugular veins. And then we've got a lot of ventilator sessions, okay? And some of these ventilators will approximate the ventilators that you are going to see in a tough situation like this one here, which is the LTV. So there's a lot here in terms of something for everybody. If this is all review, well, you know, feel free to take a nap. On the other hand, hopefully we'll make this interesting and worth your while. Some of the stuff, of course, as I was throwing stuff together, I downloaded a lot of stuff off the internet, so a lot of this might be copyright material. The attorney in me says, hey, you know, make sure there's a disclosure. Don't disseminate this, okay? So just the way it is. And of course, it's introductory, it's not comprehensive, okay? So I used a lot of variety of sources, and there's no endorsements for any of the sources I use. So you will learn. It's important that you know when you don't know. I think this is, you know, one of the things I'm going to touch on a number of times, and that's why it's a team. This is, you know, critical care is a team sport. I mean, nobody does critical care by themselves. So when I'm in the ICU, I'm working with top people, working very hard and putting a lot of thought together. We got, you know, nutrition, we got pharmacy, we've got, you know, respiratory, we've got nursing, got the PAs. There's so many people throwing information in, and you take all that and you put it together. And that's what I mean by team sport. Okay, nobody can hold all this information, you know, maintain all those, you know, 10,000 data points that you're going to get in one particular day on 12 patients in your head and try to keep all that stuff rolling to come up with a plan. You need people there. So we've got to know when we know. That's really important. When you know the answer, it's the answer. Okay, that's the absolute. Know when you don't know. Okay, but be very careful about that gray zone when you don't know that you don't know. That's kind of thinking you know the answer, but you don't. And that's why the team is so, so important. Okay, and that's the philosophy we use in the ICU. Everybody has something to say. This is the curriculum. This is how I put it together. And I think, you know, again, with Tia's blessing, I think we caught, most of the key topics that I think are apropos not only to the current situation with COVID, but also a lot of things like, how to interpret a blood gas. What are different kind of ventilator modes? What exactly is, putting in a central line mean? Okay, these things are, sort of going to come all together throughout the course of the day today. And so I want to keep this very informal. So if you have any questions, you have anything you want to add, something you think is really important that I left out, and you want the team to know, the group to know, please, just speak up, okay? It's very informal. There's only about 40 or 50 people in this room, and so I want to make this very informal. You have a question, you have a point to make, just go ahead and do it. So this is roughly how we're going to do this. Maybe what we can do is, can everybody see those slides? I was going to say maybe if we can drop the room lights a little bit. I wish I knew how to do that. I almost never speak in here, so there we go. Yeah, Jordan's on it? Okay, go Jordan. Okay, that makes the slides, I think, a little easier to see. Some of them are going to be a little bit tougher than others. So the biological MCI, well, so we talk a little bit about this. It's never a big surprise, okay? I think that, we've known pandemics and epidemics that come through history. I mean, there have been so many. I mean, here's HIV. We had various different plagues. Here's MERS and SARS. And this is actually looking at the impact of these folks. Basically 25 to 35 million people dying of HIV. I mean, that was a huge pandemic. And, if you look at the numbers here, Ebola is relatively small, but it gets a lot of news. So these things come and go. And I think as we go through things like climate change, I think as we go through, some of the evolving, the emerging diseases. I mean, look at things like West Nile virus, okay, not a benign virus, especially for some people who get afflicted with neurologic symptoms and sometimes never recover. I mean, there's a lot of things that are emerging right now that we just are not aware of, and we expect to see some of the tropical diseases migrating northwards. We're seeing more of dengue fever here up north than we've ever seen before. So why is that? It's because of the changes in the global structure. So very quickly, the Black Death. Black Death killed a lot of people. It came through Europe a number of times. This is before we knew what contagion was. We talk about, diseases like malaria. Malaria is 2 words, bad air, okay? Folks went into swamps. They did not know that it was the mosquitoes that were transmitting malaria. It was actually, they thought it was the air. It was a bad air. It's, stank. And they would go in there and think, oh my God, we're in the swamp. We're going to catch malaria. Well, it's true, but they got bit by mosquitoes. So we had no idea what the germ theory was. And of course, people were, dying, left and right. Wiped out about 60% of Europe's population at the time in the second run of the Black Death. So again, the Spanish influenza, many people have used the Spanish influenza as a kind of a comparison to what we're going through right now because it's an influenza. But again, it was 1918 through 1919, and it basically ravaged the world. And again, it also is an H1N1 virus, so very similar to what we're seeing right now. Again, we did not have critical care. You got to think to yourself, what did we actually have in the world of 1918 or 1919 that even approximates current medicine? We didn't have IV catheters, okay? So, they didn't have, the ability to sterilize fluids. I mean, these folks were dying. So the idea here is to be able to sort of bring all the knowledge and the sort of the team knowledge that we have and bring this all together to bear on folks in modern medicine. So again, a lot of people died in the past. And again, if you look at the population in 1918, the U.S. population was about 1/3 of what it is right now. But again, look at the number of deaths. It was pretty amazing. This is what the ICUs look like during the Spanish influenza. Okay, this is just a picture off the internet. But you can see, I mean, folks were cross-contaminating, right? There was no isolation here. And if you got put in one of those wards and you didn't have the disease, you had the common cold, you'd probably go home with it, if you went home at all, right? So that's the thing is basically very similar sort of situation to what's happening now, but a very different situation because we have modern medicine, we have modern critical care, and we have the opportunity to make a difference, okay? So in terms of definitions, an MCI is a mass casualty incident. So what is a mass casualty incident? It could be something, it could be an earthquake, it could be a tornado, it could be a hurricane, it could be the proverbial school bus crash, or it could be the airplane crash where there are more sick people, more acutely injured people than can possibly be taken care of by the healthcare facilities in that area. We're lucky here in Rochester because we have a lot of hospitals. Rochester Regional Health has 5 hospitals. And, University of Rochester has its own catchment area of hospitals. And so we have a lot of room. But what do you do if you're in a Midwest town and a school bus crashes? And, all of a sudden the little community hospital there is overwhelmed by what comes in. And there's 20 people, and they only have 4 ED beds. I mean, again, you're thinking to yourself, what's a mass casualty event? It doesn't have to be what we're looking at right now. It just has to be sufficient to overwhelm the capacity of the healthcare system to take care of those patients at that moment in time. The other thing is surge capacity. I'm going to talk a little bit more about this as the morning goes on. What is surge capacity? What can folks take care of in a crisis? So maybe, that little town that has 4 ED beds, well, maybe they can move some of those patients into, some of the wards or the recovery room. Maybe they can find folks, the family doc that retired, or the ED doc that retired 2 years ago, bring them back in. So again, surge capacity is being able to build resources, pull resources in order to make the surge, something that we can actually actively deal with. Okay, so managing the MCI by building capacity. It's the responsibility of the system, the ability of the system to respond. And how could we do that? It's by building a structure like what we're doing right now. When Jason's coming down, it usually makes me worried. Something's not working, right? Okay, fair enough. So incident command system. What's an incident command system? Incident command system is what the folks are doing next door, okay? They have a system for monitoring what's going on. And for those of you, who know about teams and, crew resource management is one of the fundamental principles is having situational awareness. Situational awareness, knowing what's going on around you. And that could be in a very big way, like Dr. Casey. He's got situational awareness. He's tapped into the news. He's tapped into the County Medical Society. He's tapped into the other hospitals. He knows what's happening here in this system. So he's got a tremendous amount of information feeding into him. That's situational awareness. It could be situational awareness in the middle of a cardiac arrest, where you know who's doing what. What is happening around you. Keeping an idea of things and having a structure, and that's so important to build that situational awareness into a structure. And that's an incident command center. And critical care. So here's the question: what is critical care? Well, nobody knows. Okay, you look around the world and you say critical care. Why is everybody dying in Italy? Why are the numbers so high in Italy? I mean, I love Italy. Oh my God, I'd go back there in a heartbeat, but I got to wait a little while. The fact is, it's just an amazing country with amazing people in it. But why is it that people are dying? It could be that your critical care infrastructure is very different from ours. I've had the opportunity to see a lot of different hospitals. I've been in England. I've seen hospitals in England. I've seen hospitals in Ireland. I've seen hospitals throughout Europe. And I've had the opportunity to tour some places. Okay, I've had some opportunity to go into places where, in the emergency department, you go in and anesthesia machines come out of the ceiling when a trauma comes in. So the anesthesiologist shows up and they start working right there in the room, right? So that's an amazingly technologically advanced place. At the University of Vienna, for example, their trauma center is amazing, okay? However, that's not the same thing across Europe. And so when we talk about critical care, I think it's really important that we realize that, a hospital is not a hospital, and a nurse is not a nurse, and a system's not a system. So when we're talking about a healthcare system in the United States, it's not the same as the one in Europe. And nurses who are critical care trained are different from nurses who are ED trained or floor trained. And ICUs in third world countries and second world countries, believe me, are nowhere near the ICUs and the technology and the teamwork that we have here that we can bring to bear on these kind of situations. So I'm not a conspiracy theorist, but we knew this was coming. In October 2019, just last year, they had at Johns Hopkins a simulated exercise about what would happen if a coronavirus caused a pandemic and shut down the entire global healthcare system, and what would happen to the economy and the social structure in the world. This was being funded by the Bill and Melinda Gates Foundation. And it was the Center for Healthcare Security, Johns Hopkins. It's called Event 201. So you see, the thing is, we know it's just a matter of preparing, okay? So this is some of the issues here that we have not been able to get across is how do you prepare? Where do you find the resources to prepare for things? And we'll talk a little bit about that in the future. So again, look at what happens here. Look at the number of beds that we have in the United States compared to other places. Look at the number of healthcare, the total number of critical care beds per 100,000 inhabitants, okay? So per population, 34.7 critical care beds here in the United States per 100,000. On the other hand, look at Italy, 12.5. Look at places like China, 3.6, and India, which is just about to get hit with this, has 2.3 ICU beds per 100,000 people. So when we say critical care is not the same as critical care. Critical care here is different from critical care there. Hospitals are not the same here as hospitals there. So you can't extrapolate what's going around the world. However, we still need to be prepared. And this is really a fundamental, important perspective, because I think, first of all, it should make us feel a little bit better about where we are. We should feel good about the kind of system that we have already in place, understanding that we have a ways to go, but also knowing that maybe once we get over this, we may be able to go and help, okay? Which I think is really something, the next thought, okay? The next thing down the road is where do we go, how do we get there to help folks who haven't been hit as hard and who will be hit hard in the future. So again, if you look here, number of ICU beds in the United States, we have a total number of ICU beds in the United States, about just short of 100,000, okay? That is, if you think to yourself, we have about, what did we say, about 40 beds in this hospital? Again, you start adding up the number of ICU beds, and I swear to you that ICU beds are not the same even within the U.S. The ICUs in New York City are different from the ICUs here in Rochester, are very different from the ICUs in some of the smaller community hospitals. They're staffed differently, and you know what? To a large extent, if you have a 10-bed ICU at Lakeside Hospital, okay, that is being run very differently than the 10-bed ICU here at the surgical ICU. That is being run in a very different way. You may not even have an ICU doctor at night. You may not have a PA running the ICU at night. You may have a family practice doctor running that ICU from home, okay? So again, ICUs are not ICUs. And I think this is a fundamentally important message that we need to think about because, again, how do we build capacity? One of the ways to build capacity is to make sure that everybody has access to the same level of care no matter where you are in the United States at any one time. So very quickly, why is COVID dangerous? I kind of made this list up. I didn't really have a good idea. But I know it's contagious. I know you look at the RO numbers, the number of people who get infected from one contact is pretty high. You look at the long latent period, people walking around asymptomatic. And, it takes a little while to be symptomatic with the disease. There are now reports of people testing negative who subsequently tested positive, okay? So again, there's a different kind of a weird latency there. You have asymptomatic individuals. Testing has been limited. We couldn't test all the folks we wanted to test. And some people really just had the cold. Some people have allergies, okay? And some people really have COVID. We don't know. And it progresses really fast to ARDS and basically multiple organ shutdown. There's no treatment right now. We're working on treatments, but we don't have them yet. There's no vaccine. And it may mutate and it may recur. That's what coronaviruses do. That's why kids always sick in the middle of the winter time because they sit in class and the virus they had last week went to someone else and came back again. And that's the way viruses work, and viruses do mutate. So, it's a very interesting world that we live in. So again, how does this compare? So if you look at the row number for flu, it's up here, and I don't think the laser pointer is working, but that's okay. And then you say, well, COVID-19 is about basically twice as infectious as the common flu was, okay? The incubation time is roughly the same, okay? But the incubation time runs longer. So while it's incubating, people are spreading it, okay? So 14 days, it's for 12 or for almost 10 days longer than the flu, people have the virus, but are still spreading it. I think that's really important to know because that's one of the reasons is wearing a mask in here, okay? We're really social distancing. We're trying to prevent it from moving if any of us has it, okay? Infection, the hospitalization rate is significantly greater, and the case fatality rate is also significantly greater, but we don't know because we don't have a denominator, right? So if you talk about incidence and prevalence of disease in a population, in order to truly know what the incidence and prevalence are, you have to have a denominator. You have to know what the baseline is. How many people did you test? How many people have it? How many people are carrying it? How many people really got sick? How many people died? And by the way, who are the people who died? Are they very young, healthy kids? Or are they older people with multiple comorbidities? We don't know. There's so much we don't know about this disease. But once again, we have to be ready for it. When we talk about flattening the curve, this goes back to when we talked about surge. The idea with surge is if everybody gets sick at once, then hospitals are overwhelmed. If we can sort of flatten the curve by keeping people apart, so there's not so much contagion, you decrease the acuity of the disease in the population. So you decrease the rate at which people are getting sick and needing ICU and hospital resources. That's called flattening the curve. And that's why we're in the social isolation that we're in right now. And of course, this is all news stuff to you. Everybody knows this. But it's still very, very important because what happens is if everything happens at once, if that school bus crashes and everybody gets hurt at once, it's so much worse than if somebody just falls off a bicycle or 2 or 3 kids fall off a bicycle. It's the number of people that overwhelm the capacity of the system that turns it into an MCI, right? And that's very, very important to understand. So I'm going to talk a little bit about incident command and how things work, but I'm not going to spend a lot of time on this because you probably already know. The idea here for incident command is basically to prevent, protect, and mitigate, okay? So again, knowing what's going on and basically coming up with a strategy for recovery, okay? And that's part of what, part of what the folks in that room are doing there. They're trying to use best practices, understanding how people have responded to disasters in the past. We know, we have disasters that are recurring. We had, we had the hurricane in Puerto Rico and New Orleans. We had the earthquake in Haiti. These things keep coming, okay? So folks have been able to establish best practices on how best to mobilize resources and be ready for these things and to get these things under control as rapidly and as efficiently as possible. So the goals of an incident command system are basically, you can't see this very well, but obviously preparedness, this is great. The nice thing about Rochester is that we have not been hit with what's happened in New York City. A friend of mine was a fellow here in Rochester, actually trained in Unity in the internal medicine program, went on to become an anesthesiologist, and then went on to become a critical care doc. He's now at Columbia Presbyterian. He hasn't seen his family in over 3 weeks. He's living out of a hotel. He describes the place as a war zone, okay? He called me a couple of times this past week, and basically they just say that all they can do is struggle to keep up with the people that are coming in, and people are dying really fast. And it's very helpless. It's a very helpless feeling that he has. So again, preparedness, we have the opportunity here in Rochester to learn from what's happening downstate and to see how they responded, what worked, what didn't. Okay, we also have a little time to get ourselves on our feet and prepare, right? And this is what we're doing here today, getting our minds worked into this so we can wrap our heads around this and say, oh yeah, I'm okay. I can help with an intubation. I can help putting a central line in. I know that people need Foleys when they're critically ill. Why? I'll tell you why. And the thing is, we'll go through all this stuff and how to respond. And of course, ultimately, we're all going to be part of the recovery process. And I think that's going to be tough. So incident command is basically what happens is you start to sort of build it in all the different pieces of information that your folks are accumulating. It's intelligence, right? So it's intelligence gathering. You're walking around, you're getting information flow from all the people who've been exposed and see things and EDs and, hopefully not the news. But the thing is that you're pulling all this information together so that you can develop your best operational response to the critical situation at hand. So this is how it works, okay? So ultimately, in the United States, incident command is really a federal thing. Constitutionally, healthcare is a state thing. You know, the federal government has zero responsibility for healthcare in the United States by a constitution, right? So what happens is it's all been delegated to the states. But when you look at what happens across the U.S., this is now a situation like people describe as like war, okay? So the federal government gets involved through the National Incident Command Centers, okay? And that's how the system is built to respond. So truly what happens here is that at a national level over here on the right-hand side, you see that these national responses sort of oversee regional responses, overseeing field responses, and ultimately what's happening is for us, we're the boots on the ground folks, and we're actually doing some of the work and feeding our information back up so that they can coordinate this response. What's going to happen when this virus hits West Virginia, okay, or Montana? Okay, again, the people are spread out a little bit there more, but their healthcare system's not quite the same. So this is why I'm coordinating things and saying, okay, now New York City's being battered, Rochester's getting ready, but the folks in the Midwest, may have a little bit of time. Okay, so how do we mobilize resources? How do we move these ventilators and these people around so we can help our friends and neighbors in need, right? So this is why a National Incident Command Center is so important. On the basic operations level, there's a lot of stuff happening in terms of who does what. Okay, there's information officers feeding out, the public relations folks talking to the news media. You see Rob Mayo on the news, sort of updating folks every day. But there's a lot of planning, finance. Who is actually paying for the stuff that's coming in? I mean, a lot of this stuff is we're paying now, hopefully get paid, get reimbursed tomorrow, kind of thing, right? So again, we're the operations folks, and this is what the disaster management cycle looks like. So here we are, we're sort of like we got this disaster alert that's happened. We're sort of like we've got 8 patients in the ICU, we got 10 patients in the ICU, and then what's happening is we're doing this sort of like emergency response, and then we're doing recovery. And then what we've got is a chance to go on and develop and reconstruct and sort of develop. And this is when people talk about how the healthcare system of the future is going to look. Okay, this is going to be a very different healthcare system. We're going to have, potentially, are you looking for a pointer? Thank you so much. So what we're looking for is the way that we're going to reconstruct and build our way out of this. My feeling is hopefully we're going to have so many ventilators and things in the United States that we'll be able to lend them to China or lend them to India, folks that don't have ICU resources and don't have ICU beds. We had a visiting professor here not long ago from China, and she's been telling me how incredibly understaffed they are and how the ICU just doesn't work so differently. So she made rounds with us a number of times here in the SICU. Kristen, might you remember her? And the fact is they're in total panic mode. And they just don't have the resources available. So maybe they're going to have to change too, and the world is going to have to evolve into a more homogeneous, a potentially better healthcare system going forward. So once again, I'm going to tell you, I felt so amazed yesterday, when I watched the USS Comfort Navy ship coming into the harbor in New York. I mean, we go everywhere. We help everybody. And you think to yourself, this is fantastic. We really have a system that can respond, and we have always been there when folks needed us. So success is going to failure, going from failure to success without a loss of enthusiasm. So very quickly moving on to the next thing is capacity management, very much on the heels of what we just talked about. And so, told you. All right, so the fact is that this is about how to build capacity. So what happens is capacity is built in a lot of different ways. And you have to think about what is capacity, okay? So a hospital is not a hospital, an ICU is not a hospital, there's regional variations. So what makes a winning team a winning team? And so a winning team is made a winning team by being prepared to respond, okay? It's made a winning team by getting ready and working together, bringing everybody's intellectual resources, all their energy, their emotional energy, their passion, bringing it all together to make it happen, okay? And every patient gets seen, every patient gets rounded on, and nobody in that ICU is marginalized in any way, because the person who you least expect to get the information from maybe the person that gives you the clue as to what next to do, okay? It's one of the reasons I round so early in the morning, right? So here we are making rounds, team rounds. High-performing teams, how high-performing teams work, okay? I'm not going to, there's one slide on this. I've written chapters on this, and most of the stuff here is in book chapters. The fact is that we talk about a common purpose. What are we here for? We're here for our patient, right? So, I used to argue sometimes, we have, especially not so much here in Rochester, but I walk into an OR somewhere, in Pittsburgh, and the thing is, we have a disagreement as to what should happen next. And we ask ourselves, who's the most important person in the room? Well, the surgeon would say, yeah, of course. That's it. Yeah. The truth is, it was a patient, right? It's all about the patient. We're focusing on the patient. So it's common purpose. We have clear roles. We know, our strategy, how we're going to cooperate. But what happens is those roles mesh, okay? And that's so important because those roles are meshing, and we have executive decisions being made by people right at the bedside. There's so many times a nurse comes to me and says, this patient needs to be on amiodarone. Darn, she's right. Let's go. And the fact is that, these are executive decisions being made by experienced people who are used to working as a team. And when everybody is open to that kind of information flow, things work better. Okay, that's how teams function. Okay, everybody has a role, but those roles can mesh sometimes. Okay. So the quarterback can actually run the touchdown, right? So the thing is that, the structure for cooperation, okay, leadership, effective process, the climate for cooperation, and that's why we call it a unit. So when we talk about units, like if we talk about units like in the Army, or we talk about units in the DOD, or we talk about, when we talk about units, they are meshed. Those folks are meshed. They are working as a team. So critical care unit, to me, means that it's a team of people. It's not so much a place. It's a team of people. And that is why when I talk to you in the next few slides about where we can do critical care, heck, we can do critical care anywhere, as long as I got my team. Okay, that's all that matters. Okay, I've got the people who can make it happen. And, we've got folks, we've got passion, we've got energy, we've got knowledge, and we're going to bring that to bear. It doesn't have to be in the ICU. Okay, and that's so, so important. So, barriers to preparation. What are some of the things that stopped us from being prepared for this? Well, just-in-time purchasing. Hospitals can't be, ready. You can't build stuff in the back room and have it sit there, because what's the first thing you look at when you pick up a vial of lidocaine? It's the expiration date, right? Is the lidocaine still good? It's still good, right? So the fact is, we know that. But the fact is, we have to throw it out, because the Joint Commission's coming in. They're going to make it slow. They're going to cite us. We found a vial of lidocaine that was expired. So the fact is, or we found a central line kit that was expired, okay? Is it still good? Probably, okay? But it has an expiration date on it. So a lot of the stuff is not a matter of being prepared. It's a matter of being fundamentally disorganized. It's a matter of being fundamentally, I'm a lawyer, right? So I love to break rules for other people, right? That's the idea. You find ways around problems, right? So the thing is that this is the problem. Somebody made a rule. Okay, this expired in June. Okay, well, is it still good? Probably is. But God forbid you put it in someone, they look at the expiration date and get an infection. Maybe they would have got the infection anyway. But this is what happened. Now we have resources sitting. How long is technology good for these days? How long is a ventilator good for? What's the half-life of one of these ventilators sitting in a box, Sean? It's probably about 5 years, right? So the thing is that, you start looking at new technology, the integration of technology into the EMR, okay? So again, our EMRs are changing constantly. So again, technology, maintenance, storage costs. Joint Commission comes, they find you've got a whole batch of stuff sitting in a hallway somewhere. They're going to immediately, look at a citation. It's hard for hospitals to be truly prepared in today's climate. And we've also had a need to prioritize resources in other places. Community health, things like health wellness programs, preventative health, and so forth. So really and truly, strategic dissonance is the old model here, and then looking ways to adapt and succeed instead of retrenching and failing. This is why we say thinking out of the box or thinking differently is so important. Am I talking too fast? Okay. So is stuff still interesting? Okay, if people start going for lunch, I'll know exactly what's going on. I take a hint pretty well. But this is what happens to our system here, okay? Our system doesn't have a whole lot of slack. Remember I showed you the slides that most of our ICUs are running about 80 to 90% occupancy? That's here in the United States. That's here we have a lot of ICU beds and we're running 80 to 90% occupancy. In fact, years ago, Kristen and Taylor will tell you, we had to develop, 4200 as a step-down unit because we had so much capacity. We were lacking so much capacity. We had so many patients, so much demand. And so we had the need to build capacity into the system. And so the fact is, that's why the critical care tower is going up with all the new beds, because you're never going to have enough beds to take care of the needs of the future population as we get older, as we have comorbidities, as technology increases. People who had surgeries, or were not candidates for surgeries, like aortic valve replacements, 10 years ago, are now getting TAVRs, okay? So technology is changing. People are older and older. People are coming in, and, they're 94 years old, and they're coming in to have a TAVR, right? So the fact is, this is going to be the paradigm of the future. And what happens is that capacity needs to be there. So what happens here is you can see that over ICU capacity, below ICU capacity, 1 or 2 patients can push you over capacity. And that's really important. So overwhelmed, limited capacity by a small change. So one theory is the hospital of the future is going to be an entire big ICU, and then there will be very few sort of like, long length of stay beds. And then where do you provide critical care? And the answer is anywhere, right? So it could be here, it could be in a small community hospital, it could be on a ship floating in the harbor, or it could be at a new critical care center. So how do we build capacity? Capacity is, again, 3 things. We have capacity in room, places, okay, right here in front of the auditorium. Okay, capability, people being able to do things, people being shown and feeling comfortable with putting a central line in, okay? It's not that hard, okay? And the thing is, we're going to learn how. You're going to at least learn how to assist and be there, how to intubate. No, it's not that hard until it's hard, right? So again, and strategy. We have to be able to have a strategy to get around this. So again, what is the goal of critical care in an MCI? Is to provide key critical interventions as soon as possible to as many patients as possible in a reasonable way, right? And what is critical care? I always love it when families come in and say, well, you cured Dad. I'll tell you honestly, I had nothing to do with curing Dad. Okay, I didn't do surgery on Dad. I didn't do anything to Dad other than support his organ systems while he got through the worst part of his disease, okay? So we don't cure people in the ICU. My team doesn't cure people in the ICU. We take care of them, okay? So what we do is we support failing organs. They're going into renal failure, we're going to give them some fluid, we might put them on dialysis. They're going into shock, we'll find out what it is, we'll get some cultures, get the right antibiotic on board. All we do is support those failing organ systems. So if we're not curing folks, that means we probably could do this in a lot of different places. So those of you who don't know, but this is Central Park just a couple of days ago, okay, in New York City, okay? So they're going to start doing critical care in these tents in New York City because this is building capacity. This is building extra rooms. This is where you convert the Javits Center into a big hospital, okay? So you build the room, okay? Now, the problem is you have the room. You still need the people. And you all are the people, okay? We all are the people who are going to try to make this happen. And you can have the capacity, but if you don't have the people, you don't have the knowledge, you don't have the skills, it's not going to work, right? Vicky's going to tell you at the back of the room, asking me to do a small bowel resection just would be a bad idea, right? But the fact is, these aren't such complex skills. These are skills to know how to monitor and support organ function, so that we can go ahead and get people over the hump and allow their bodies largely to heal. Okay, their bodies are going to get over this with a little bit of help. So where do we do critical care? Dr. Casey already talked about this a little bit. In the ED, and we do it in observation a little bit, okay? In ICUs, obviously, step-down units, okay, step-down units. ORs are fantastic capacity for this, okay? You can put 2 or 3 people into some of the bigger ORs that we have here. Those ORs, and I'll tell you later, are negative pressure rooms. An OR turns over all the air in the OR about 6 to 10 times an hour. Wow, okay? That's a serious negative pressure room, okay? So the fact is, if you have a ventilator, you have monitors, you have a bed, you bring in more beds, all of a sudden you have an isolation room for 2 people, okay? You can actually make it into a room where a nurse can take care of 2 people right there in the same room all the time, okay? So you're building capacity. You got to look out of the box. You got to learn how to think differently. How about PACU and recovery rooms? These are amazing. These are open areas, so not so good, maybe not even as good as the operating rooms are. Okay, but they are, in fact, telemetry units. They're piped in for air. They're piped in for oxygen. You could run ventilators there, and they have suction, so you can take care of people in a recovery room. All telemetry units. And, of course, building outside facilities. And it's very interesting. This morning, we're setting up the ventilators with Sean. We realized we didn't have a gas tank to power it. And we realized, you just need these little basic things to make it happen. But look at this. Now you have a portable ventilator. You didn't even need to have the oxygen piped in here, as long as you have tanks. And I'll tell you, in Sweden, when the polio epidemic struck, a lot of people ended up on ventilators acutely. What happened was they would find students, high school students, and medical students, and college students, and they would bag people. And they would bag people in shifts. They didn't have ventilators, okay? So they came up with creative solutions, okay? So it's a matter of building capacity. It's a matter of building talent, skill, and just making it happen. So here's the operating room turning over its air 10 to 15 times an hour, which is pretty amazing, okay? So the ICU is really consolidation and focus. It has an infrastructure with gas, data management, that's the EMR, communication, telephones, for example. You can use your cell phone if you really have to. Equipment, ventilators, monitors, pumps, access to imaging and labs. People, okay, trained providers at all levels of support, okay? This is everybody. If I have somebody who comes in and it looks like they came in with shortness of breath, and it turns out that a fair number of times people come into this hospital with shortness of breath, it turns out to be a perforated viscous. Okay, so the fact is you never really know, okay? But as long as you have radiology and supplies, and you have the ability to mesh these things, you can actually build the system. And then you need supplies, okay? So you need to have IV fluids. You need to have certain things. And again, some of this might be, in fact, we might be that we're throwing it out too soon. So this is how you make it happen. So it's a matter of space and stuff and people, okay? That's how I kind of look at this in my head. It's space, stuff, and people that makes capacity happen. And in order to make that happen, you have to have training. You have to have staffing, some kind of a staffing grid, right? So people show up and they all show up at the same time. They're scheduling. You have to have work pods. People work together well as a team. And what happens in the ICU for us is that there's always a resource. That's one of the things that makes an ICU nurse, so powerful, because they have a buddy system. And some nurses have only been there for a couple of months, and some people have been there for years. And the buddy system means that if I'm running into trouble, I'm not 100% sure what to do, I've got another nurse to help. So that's why if you have work pods, you've got that buddy system to help each other out. That's one of the reasons why putting an ICU nurse by herself on a whole floor somewhere away doesn't work so well, because the team is now broken up. The work pod isn't together, okay? So nursing buddy system, very, very important in order to, for patient safety and in order to make people, comfortable with what they're doing, especially when things are getting tough. Okay, you have two patients, one's beginning to code, where do you go, right? Contingency plans, you gotta know what happens if somebody gets sick. People don't show up to work. And supplies. You got to have supply chain management, repurposed policies, ways of making things happen. Now we're looking at sterilizing masks, okay? Again, so people are coming up with new ideas and substitutions, things that, we never used to do before, but we're doing now. So people come in from the EMS, okay? Many people start critical care in the EMS. The EMS wagon is actually a critical care wagon, right? So people get intubated there, they have fluids, sometimes they're getting defibrillated, they're getting CPR, and then what happens, they get to the ED, where this escalates to a whole different level, right? So in the ED, there's a new kind of critical care. So people are now they're now in the system, okay? They're formally being admitted into the system. Some of these folks will go, to the ICU directly, and one of a number of different ICUs. Some of these folks never go to the OR, and they go directly to the ICU. Some have surgery, they go to recovery room. And some of these people go into different areas in the hospital. So neurointerventional, for example, before they come to us. So critical care happens in so many different places in the hospital. We cannot forget that. It's not about the ICUs per se, okay? So again, surviving critical care. What happens, what's the survival statistics show? If you have ARDS, you have a 40 to 65% chance of surviving ARDS, okay? That's pretty good, okay? And severe sepsis, 73, and septic shock, about 50% survival. These are national numbers, okay? These are US kind of statistics. So what happens is, however, realizing that if you don't get access to critical care, you're not going to survive at all, Okay, these are life-ending situations if you don't have access to critical care. So surge management, just to recap here, space, you need staff, you need stuff, and then you need standardized care. Okay, so again, you want to sort of be able to do this, like, in a national disaster, what's happening in New York City, for example, where there's so many people are going to argue for years about what was the applicable standard of care, okay? And the fact is, we are going to sit back and argue this. The fact is, people got admitted to the system was overwhelmed, and people are doing the best they can, okay? We now see people being licensed in multiple different states. One license is good anywhere. With the standards, these things, these rules are starting to change a little bit. And so we start looking at resources, again, sort of sharing resources perhaps as time goes by. This slide's in your handout. I think it's worth looking at because it's a way to develop capacity. The most perfect solution is often a good theory. So again, we have lots of theories, but out of that come ideas and potential solutions. This is what happens when we talk about tiered staffing. And so folks in disasters start looking to say, well, expertise. So I've been doing critical care since about 1992, okay? So again, I guess I know a couple of things about critical care. I've worked in a number of different places. I've written some chapters. I've lectured a little bit. That doesn't mean I'm great, okay? It means that I've done some stuff, okay? Again, so what happens is there are folks in this room who did some critical care during their training. I'm thinking perhaps of surgeons and other folks who have sort of built that experience, but they're not actively using it. And then we have folks out there who are ICU PAs. My ICU PA team is second to none. Okay, they're fantastic, and so they're me when I'm not even there. Okay, I mean this is the stuff just goes, it happens. On the other hand, there's PAs in this room that maybe did a little bit of ICU stuff, and maybe kind of need a little refresher, or they need a mentor or somebody they can go to for questions. And then the same with nurses. So this is what happens. So you find someone up here who can say, okay, well, fine, this is the ICU person, okay? Or, maybe, this is the ICU person up here, the experienced critical care physician, and then here you have an ICU APP or an ICU physician. It could be an anesthesiologist, okay? Anesthesiologists do ventilators, do lines, they do fluids, but I'm sure they probably don't understand TPN, and they might not, always choose the right antibiotic. But the fact is, they're still ICU. It's still critical care in a way, right? They do life support of patients under anesthesia. So again, I'm an anesthesiologist by trade. So again, you learn how to do this stuff in school, and then you find a number of other people who can oversee or sort of collaborate with, more and more sort of PAs and doctors and nurses, CRNAs, ICU nurses, and then you sort of build this pyramid out where all of a sudden, one person can touch a lot of lives. And then one person in here similarly can touch a lot more lives than they could is if everybody always was waiting for the ICU doc to show up, right? That's how a team functions, okay? I keep hammering the story about the team because that's how this works. And this is what we're trying to do. We're doing this tiered staffing for pandemic preparedness. So what do? What can people do on a team? They can do patient assessment. And recognizing a sick person is really important. Recognizing when things aren't going well, really important, okay? So again, this is key, okay? So again, patient care, there's things in patient care that need to be done that, folks can help with. There's documentation that can happen, okay? People can write notes while other people are doing things, okay? Administration of fluids, okay, when the IV bag runs empty, do you really need the ICU nurse to go ahead and hang the next bag? No, but people can help, okay, so everybody can get in there, and, you might be able to see people even doing things that, that they traditionally didn't do before. And I'm very famous for this in the ICU, because I always push people out of their sort of comfort zone, and I'll ask a tech who's never set up an A-line to set up an A-line for me, but I'm watching everything she does, right? So the fact is, now she knows how to do it, okay, so this is really important. So you're sort of building skills upward, okay, and that's part of what we do. Looking at data. I mean, when I'm at a code, I'm looking at who's got the labs? What was the potassium this morning? I mean, I don't want to be in the EMR looking that up while we're running a code. I want to be focusing on the code, but there's people out there getting this information, gathering intelligence, moving things around, so I can focus on something else. And I don't have to be the one doing CPR because there's a team there, right? Assistance with procedures. So what do you do when someone's having a tough intubation? And we're going to talk about this later. You know, having someone at your side is so important who knows what you're going to need next, okay? And sometimes you're not even thinking it. And I'll be struggling with an intubation, and Kristen will say, you need a bougie, don't you? Yeah, I need a bougie, you're right. Go get me a bougie. You know, I didn't even have a chance to say it. And the fact is, we're on it already. So knowing what to put in someone's hands. In the OR, when the anesthesiologist is intubating, who is the first assistant for that intubation? It's a circulating nurse. Circulating nurse never leaves the side of that patient and focuses on that patient until that airway is secure and the anesthesiologist says the airway's in, okay? Because if something goes wrong, you need someone to grab things, push a little cricoid pressure, throw you the suction, whatever it is that comes next. You need to know what's the job of a good first assistant in the OR. Dr. Vernikar, it's to make the surgeon look good, right? Absolutely. So the fact is that it's a team, okay? It's the focus on the patient. And so, you know, and people who know when you're struggling or you're having you have a question or you're not completely sure here, you can't visualize the cords, the vomit's coming up, bad things are happening, they need to be able to help you. They need to be able to anticipate, and they need to be able to be your extra set of hands, okay? So very, very, very important, assistance with procedures. And then sometimes talk to families, okay? So to take care of some of these things, they just, one person just can't do it all, so that's why it's a team. So critical care nurses supervise and advise non-critical care nurses on critical care issues. So you get a floor nurse. We said that a nurse isn't a nurse isn't a nurse. What happens is that, an ICU nurse has special skills. Recovery room has, nurse has many of those skills, but not quite all of them. They have different skills too. And you put the two together and they've got some great ideas. But now you bring in a floor nurse. Look at the floor nurse. She went through this once upon a time, but, she hasn't done it recently. It's not fresh in her memory. She hasn't sort of had that hands-on training and the years of experience. So now all of a sudden you've got some, great things going on. So how about titrating vasopressors or sedation? So again, one non-critical nurse, to two patients, three non-critical nurse collaborating with one critical care nurse, and all of a sudden, what have you done? You've developed this tier, this pyramid, where you can extend your resources so much better, right? So again, tiered healthcare providers, one non-intensivist to 6 patients, 4 non-intensivists to 1 intensivist, and you've built this sort of tiered structure down where you've got one intensivist seeing 4 non-intensivists, and the non-intensivist is seeing 6 patients, so this intensivist can now see a lot more people than they normally would be able to, okay? So again, non-intensivists, they respond to changes in patients' conditions, they document, they do non-critical care medical issues, and then they work with the intensivist in consultation. Again, intensivists manage acute emergencies and ventilator issues. There's an unwritten rule in the ICU where, I'm not allowed to touch the ventilator. Sean, do I ever not touch the ventilator? No, but whenever I touch the ventilator, what's the first thing I do? I tell you, right? And then Sean comes running to see if I broke it or not, right? And so the fact is, this is how it works, right? So you've got the experts, right at the moment. Again, non-intensivists are getting critical care training, and we're working on order sets to make it all easy, of course, and then we modify. So this goes back to what we talked about before, building a capacity in people capacity by being able to develop this strategy, this tiered network going downward. So, okay, so how would we define critical care? Here it is. CMS, okay, the all-knowing CMS tells us what critical care is. It's critical care defined as direct delivery by physician medical care of critically ill, injured patient. What is critical illness? It's an injury that impairs one or more vital organ systems, and that there's a high probability of death or imminent deterioration. And critical care involves high complexity decision-making to assess, manipulate, and support vital organ systems. And this is for anybody who ultimately will need to know, you need to spend 30 minutes with the patient, okay? So these are some of the critical care codes. So critical care interventions, and we're going to spend a little bit of time on this afternoon. What are some of the things we got to do? You got to manage an airway. Okay, so the old story is if you can't breathe, nothing else matters, right? Anybody disagree with that? Okay. If you can't breathe, nothing else matters. So the way it goes is that you basically need to support an airway. People get into respiratory distress. When their organ systems are failing, there's a million reasons they'll get into respiratory distress. It doesn't have to be pulmonary. It can come from the belly. It can come from so many different places. It can be central. They could have had a stroke. Okay, they could be hypoperfusing. Okay, they're getting delirious and they can't breathe. There's so many reasons. You got to be able to support an airway. Individualized mechanical ventilation, folks. One ventilator setting doesn't work for everybody. I don't know. Sean, does it? Oh, okay, fair enough. So it's individualized mechanical ventilation. We need to know how to get access. Intra-arterial pressure monitoring, so we can measure continuous blood pressures and sample arterial gases if we need to. Vasoactive medications, arrhythmias, coagulation, and going back and assessing, the feedback loop in the ICU is one of the coolest things, because, if your family practice, somebody comes in and you give them something and they say, well, I got some high blood pressure, and you come back in 2 weeks and see if the blood pressure is better. So the feedback loop is kind of long. If you're in the ICU, you're giving somebody a dose of cardizem or a dose of cardine, and you're dropping the blood pressure really fast, and you're watching a feedback loop is really, 2-3 minutes sometimes, okay? So again, a feedback loop for interventions and reassessment is very, very fast, and that's why you need vigilant people who are experienced and know when to recognize problems right at the bedside. Again, electrolytes, renal replacement therapy. This is when the nephrologists come in and help you decide when a patient needs to go on dialysis or CRRT. Sedation, anesthesia, nutrition, these are all critical care skills, and many of these really go back to the idea of supporting the end organs while the patient has the chance to recover, okay? Treating the pneumonia, but letting them breathe on the ventilator so they can actually get over this acute illness. So this is where, we do other things as well, prophylaxis. And it's really important to think about these things. We have bundles in the ICU to help us remember about DVT prophylaxis. Well, who gets it and who doesn't? Well, if you had a craniotomy yesterday, you're not going to get sub-Q heparin today, right? I mean, pretty obvious. But on the other hand, if somebody's immobile and maybe they came in for cancer surgery and they're laying there paralyzed, they're going to have potential for a blood clot and a pulmonary embolism. How about GI prophylaxis? Making sure they don't aspirate, making sure they don't get a stress ulcer, keeping the head elevated, probiotics. I don't know if they work or not, but they probably don't hurt most people. So you prevent them from getting an infectious diarrhea when they're getting antibiotics. They don't come down with C. diff. Endocarditis. Somebody comes in and they had a valve last week, then they had a stroke afterwards, and then now they have a pneumonia. Well, okay. Well, you better be thinking about the valve. Okay, the fact is you've got to be, or somebody comes in with a vascular graft. You better be thinking about the graft. It's a foreign body. It's going to be seated. So you got to think about prophylaxis sometimes to make sure that they're going to get chronic suppression therapy and the right antibiotics right up front. Multivitamins. I'm a big fan of thiamine. Okay, why is that? Because thiamine is metabolic support agent. Okay, it helps the body build ATP. Okay, well, ATP is the high energy currency of the body. So adenosine phosphates in various NADP, ATP, cyclic AMP, whatever it is, has a P in it. Basically, that's it's thiamine dependent. Okay, so in order to build that, critically ill patients are using this a lot. And so there's actually, I'll talk about lactic acidosis in a little while. There's actually a type of lactic acidosis that is actually because you don't have enough thiamine in your body. I'll show you the slide later. So the fact is, this is things to think about really early on. They don't all have to be alcoholics to get thiamine, right? So pain and delirium prophylaxis and management. Folks get delirious when they're, especially older people. They have anesthesia, they wake up, they don't know what day it is, they pull out their tubes. I mean, you got to think about how best to take care of that. Decubitus prophylaxis, making sure that they're being turned. And, LOP. We will talk about LOPs later, but this is a lung opening procedure therapy to make sure that they don't get atelectasis. So Sean will be explaining that as we go down the road, and managing secretions. And so that's where we are. I think we're making progress. We're on to number 4, triage. So again, where do we stand? First of all, let's stop for a second, because 1, I need to drink some water, and 2, I want to see if there's any questions. Any questions? Anybody have any points to make? Okay. Am I talking too fast? Am I keeping you awake? Okay. All right. So, fair enough. Okay, so the next thing we're going to talk about is triage. And again, this is kind of the introductory stuff. Okay, it's not really the critical care stuff, but we got to know this. Because unfortunately, this is going to potentially come down the pike really soon, okay? And this is more about managing disasters than it is about managing the ICU. But I'll tell you, sometimes people have to make uncomfortable decisions. When you have unlimited resources, everybody gets some. When you don't have unlimited resources and resources are limited, then some people do and some people don't. And this is very, very difficult from an ethical perspective. So if you talk about, who gets what tag, who does the triage? How do you do the triage? So nobody likes to do triage, but you need somebody who's got a lot of experience. You need somebody who can recognize a sick patient and tell the difference between a sick patient and a dying patient. You also need to recognize the people who don't need to come in at all, okay? So maybe not everybody who has who has COVID needs to come in, okay? Maybe some of these folks can go home. Should they go home? Should they be observed? Maybe they need to be admitted. Maybe they need to go directly to the ICU. Maybe they need to be intubated in ED. So you have to be able to assess that patient and get a sense of how sick they are. And, I'll tell you, that's kind of a skill, and it's a tough one. So, here's a problem. I'm going to start this one off with a problem for people to solve. So 1 ventilator available. You have 3 patients. So 1 ventilator. We hope that this does not happen here. They all need to go on the vent. It's clear, okay? So one is 48 years old. She's single. She's a mother of 2. Second is an 82-year-old man with severe emphysema who depends on home oxygen and is a big donor to the hospital foundation. Another one's an 18-year-old woman with a history of drug abuse. Thoughts? What's that? Single mom? Okay. Any other takers? You're absolutely right. However, at some point, there will be a ventilator allocation team. There's an ethics committee who's going to look in on this. But at some point, you may be the person who's going to have to make some of these decisions, okay? And Vic? You're absolutely right. And how do you make that decision? You score them. Okay, and that's really important. We're actually, you hit the nail on the head. There's going to be a scoring system involved. And anything else? Right. So you're going to use the scoring system. So you're going to make it objective, right? And you're going to make it sort of non-biased. So it's not being, the decisions aren't made because of, right? So you're using objective criteria in a non-biased fashion, probably looking at all the constellation of things, right, that may be involved in this. Any other takers? What's that? Right. What's your name? Patrick. I think what Patrick says is very wise, okay? And in fact, I just ran through, I recently did a book chapter on triage. And the thing is, I've written a couple of editorials for critical care medicine on triage. And the fact is that it's not that simple, right? So you got to look at some of these other sort of things, and looking at scoring systems can be very, very misleading, okay? So people have advocated the use of the SOFA score, and I'll talk about what the SOFA score is, for triage. And other people have totally ripped that apart, saying the SOFA score is absolutely not a good triage tool because it's not comprehensive enough. It makes it objective, it makes it non-biased, but it is not comprehensive enough. So anyway, so probably the right answer here is we need more information, right? So let's go take a look and see let's work through the whole notion of triage first. So, basically, A scale of disaster determines the need for triage. If it's, if it's a hospital disaster and what happens is the ICU or the ED is overrun here at Rochester General, what do? We go code red and we divert, right? So there's other community resources available to us under normal circumstances to be able to move people in and around the local system, okay, without having to air evac them out to New York. I don't know if anybody's ever going to get air evac from New York here, but I'll tell you, people have talked about it this past week. But again, it has to do with how well the regional structure is built to be able to augment and be able to respond, even if, I'll tell you, when I was medical director of the OR at Strong, it happened to be 9/11. And what we did was we paused all the ORs, and we said, no new ORs are going in. And within 2 hours, we realized, ain't nobody coming up to Rochester from New York, okay? So the fact is, a lot of this stuff is very, very regional, very local and dynamic. So as long as you have ability to move people in between systems, you can probably get by. So again, how crazy is it to think that maybe somebody comes to Rochester General because, we're an amazing healthcare system, but they're low acuity and they get triaged out into one of the other community hospitals, maybe Geneva, one of the hospitals that we're not even affiliated with. These transfer agreements or these restrictions that we used to have may no longer apply in situations of dynamic, critical decision-making. So again, what happens is if the whole system goes down, that is a big, big deal. And then you really have to start looking at triage on a mass level, okay? So again, if this is your ICU capacity here and this is with time, this is the way it goes, okay? This is normal operations, okay? Sometimes you're 100% and sometimes you're 90%, sometimes you're 80%. This is normal operation. Kristen will tell you, I come in the morning, where'd the patient go? I had to send him out. Why? Well, we got another one, okay? So we had to decide who gets to go first, okay? So sometimes it's a reverse triage. Not so much about who gets to come in, but it's also who gets to leave first, okay? So triage has two sort of prongs to it. And again, we're moving. It's a dynamic capacity. That doesn't mean that even though you just got extubated 4 hours ago, maybe there's someone who needs to take your place because you're the best person to go. And this is just a decision that is made in real time by people who have the experience. Then you have code orange situations where we have, we're sort of helping out and we're sort of working and we're stressing the system a little bit. We're at about 150% capacity. And then you start to get into this kind of capacity that Dr. Casey was talking about this morning, which are really the mass casualty incidents where we're sort of modifying even the standards and the delivery of care. So everything is on the table now, okay? We are trying to sort of target resources based on some kind of ethical principle. And we have to be able to make this work in such a way that it's going to survive scrutiny the next day, okay? So the term comes from the French term to sort or select, and they used to talk about triaging fruit. Right? What kind of fruit went into what basket, okay? What kind of grape went into what kind of basket? So that's where the word comes from. But there's a couple of principles when it comes to folks. One is, egalitarianism. Egalitarianism is the principle where resources go to those most in need, okay? So again, how do you define those most in need? Well, we try to make it equal. We try to make it so that everybody has an equal shot at the apple, okay? And that is important, okay? If everybody's going to have an equal shot at the apple, then some people will get the shot, but the second person coming to the apple, they won't get an apple because it's already been taken. It's already been eaten, okay? So that's the problem with egalitarianism, is that everybody gets to show up. Everybody gets a chance, but there's only one apple, okay? And that's a problem with triage and egalitarianism, is that you really, it's the first come, first serve. You're the first person to get it. You get it, nobody else does. On the other hand, there's a utilitarian type of picture where we talk about the greatest good for the greatest number. And this is where we're trying to decide how to allocate. Maybe somebody got the ventilator yesterday and they look like they're dying today. Maybe it's time to take yesterday's patient off the ventilator and put today's patient on. That's where this starts to get really dicey. That's when we're starting to talk about real ethics in triage and real tough decision-making. And that's one of the reasons Dr. Herman is going to be here soon to help talk about some of the moral distress kind of situations that are going to come up in this kind of arena. So scarce resources, trying to provide the maximum benefit for the population at large. It means that some people who might have been saved, okay, if they were using an egalitarian type of principle, now are not going to be getting their shot at the apple because it's a matter of the best for everybody, okay? It's a matter of sorting people based on their immediate need and their acuity, but also the probability that what you do will be able to make a difference. Anybody here been in a situation where somebody comes into the ICU, you see the patient, you've been with the patient 2 minutes, and you know the patient ain't leaving? Okay, all right. Okay, we all know that, okay? And that literally happens to me every day. And then I think to myself, well, maybe they're leaving the ICU. They ain't leaving the hospital. Because the ICU is easy, okay? I mean, you've got amazing resources, you've got amazing people. You know, it's great, but then they have to survive the rest of the trip, okay? And we know that, you know, you can look and you can tell, and it just doesn't, you know, you look at the data, you look at the history, you look at the progression of what they've been through, and you know right away that this person has no chance, doesn't matter what you do, okay? But we do it. Okay, we do it anyway, okay, because that's what we do, and that's the way we've been trained to do things. And we've been lucky enough to have all the resources we need in order to be able to give everybody that shot, okay? But in a situation of triage, all bets are off. All bets are off because now all of a sudden you only have one ventilator, okay? So you have to make some tough decisions. So what's the principle of justice? When we talk about ethics, we talk about biomedical ethics. We talk about, you know, basically 4 principles. The first principle is the principle of autonomy, and that's that every person has the right to decide what they need, what they want to have done with their body. Okay, so you get to decide whether you want resuscitation, whether you want surgery or not. It's also the fundamental precept that underlies the issue of informed consent. So if you consent to surgery, you have the choice to consent, but you also have the choice to refuse, okay? And that's the principle of informed consent. What's going to happen with informed consent, by the way, now that we're in a very tough situation? And well, we certainly won't be able to get it in writing, right? We probably will try to get it over the phone. And by the way, is that really informed consent when you talk to somebody on the phone who doesn't get a chance to see what grandpa looks like, but still kind of makes decisions because they're trying their best? They haven't seen granddad in 2 weeks, okay? So the patient's been in the ICU. So it's not, you know, so informed is part of the informed consent process, is making decisions based on data. So if you have autonomy, and we have respect for autonomy, then informed consent is the basis for the first principle of biomedical ethics, okay? The second is the issue of paternalism. Paternalism used to be, okay, the notion that people would make decisions based on what they knew that you didn't, okay? Because healthcare providers, we've always been smarter than the rest of the population. So it wasn't hard for us to tell people what they need to have done. So that was paternalism, okay? So that kind of fell apart as we start to move into the notion of autonomy, and that was very, very important, okay? So that was the opposite of autonomy is paternalism. There's, you know, justice we'll talk a little bit more about. Beneficence is the need to do good, okay? So we're all healthcare providers, we try to do good. And you see, you know, even in news media, people are talking about healthcare providers. I mean, you know, we're a special breed, okay? We're at the bedside. When things are tough, we're there. We care about the patient. We want to do good. And non-malfeasance is the need or the edict, if you wish, to not do harm. Remember, above all, do no harm, right? So that was, you know, that was the mantra for many years. And again, it goes back all the way to the Hippocratic Oath. So again, you know, the Nightingale principles. So again, you know, this is something that's been entrenched in us as we went through our training. The principle of justice, okay, is a moral obligation to act on the basis on fair adjudication between competing claims. So trying to decide how you can make it so that everybody gets what they sort of deserve under the circumstances, okay? And I don't mean that in a facetious way. You're giving them what they deserve based on their clinical presentation, based on the probability of survival, and based on, you know, the resources that you have available. So these things all come into play as we talk about the principle of justice. The principle of justice is the underlying principle that drives the notion of triage. Okay, so how do we make decisions in triage? Well, we look at the characteristics of the patients, and under these very special circumstances, these routine patients, they're not routine anymore. We sometimes do triage a little bit on routine patients as well, but that's, you know, this is kind of like the situation where, you know, patient has something horrible happening, and should I offer surgery? Should I offer a craniectomy for someone who has a massive left hemispheric stroke and they're 90 years old? Maybe not, okay? So again, we do these sort of silent kind of triages sometimes, okay? We used to talk about these things in, you know, in school, or, you know, even in the hallways once upon a time, as the slow code, right? So the thing is, we did a lot of this sort of triage once upon a time. That wasn't real triage, okay? That was like our imposing our values on other people. That wasn't quite right, okay? None of that is right, okay? But the fact is, real triage is very different. It uses the ethical principles, and I think someone here said that there will be a team who will use these ethical principles to justify the decision-making in real time. We've got to take into account some social values or societal values, okay? Because society is not going to really take this really happily, okay? They're going to think to themselves that there's something going on. People are suspicious. Why didn't my dad get the ventilator? Why did someone else get it? Oh, they must have been special, right? Political pressure sometimes is a big deal in triage. Resource availability, ability to predict outcome, and then once again, you have to think about the medical legal fallout and also the psychological aftermath. Once again, Dr. Adam Herman will talk a little bit about the psychological aftermath of triage. So opportunities for triage occur in a lot of different places. They occur in the field, you know, when the EMS gets there, in the ED, when they first hit the critical care unit, and then reassessment of benefit. And this is when we talk about, you know, taking people off ventilators, and also taking people, discharging them from the ICU, sometimes prematurely, knowing things won't go well, but because we know that we have some tough decisions to make. So again, this is a feedback loop. You know, you continue to sort of reassess whether the resources that you have committed and continue to expend are sufficiently being utilized or appropriately being utilized in that particular context. Okay, very, very complicated decision making. So limited resources, what could resources be? Well, we talked about it, right? It's persons, it's stuff, it's places. So again, it could be trained personnel, it could be any ventilators, medications. We don't have enough, medications to go around, monitors, blood pressure, blood products. Sometimes people might be hemorrhaging and we just don't have the stuff to give them. So the goal here is minimum qualifications for survival. If you have a good chance for survival, and you will not extensively exhaust resources. If you, as a one person, are going to come in here with bleeding varices, and we only have 50 units of blood in the hospital, but you're going to take 30 of them, okay, you may not be the person. Okay, it just works out that way. You are going to use substantial resources that are going to be committed to you and you alone. And this is another principle we have to think about when we talk about triages. And will not cause others to die. Because if you take resources from someone else, then you are depleting the system of available resources to take care of other people who might have a better chance of making it. Very difficult things to think about. Not the way that we have traditionally practiced in our careers, okay? So we start to look at the low probability of survival. Okay, these folks might be denied access to critical care resources. So this is the cutoff, okay, for looking at critical care. Medium and high chance, well, they get some access to resources, but this is dynamic. So what happens if we have to move this bar up? And we have to deny some of the medium folks chances, okay, because now our resources are being depleted and expended. Again, so the criteria can move up and down depending on resource availability. So again, patient demand, predictive ability, okay? Predictive ability, not predictability, resource availability are all dynamic situations. Sometimes I tell people that, you know, you have to go down the road a few steps before you get a sense of what kind of road it's going to be and where it leads, okay? And the thing is, you can't usually tell where the road leads right at the beginning, but sometimes you can, okay? And this is really important when we talk about predictive ability. Sometimes you do something, you put them on the ventilator, you see if they respond, they look like they're going to get better. Interestingly enough, when people seem to go on the ventilator with COVID, they don't usually tend to get off, okay? It's a very tough scenario, and it doesn't seem as though those folks are weaning very rapidly, okay? And again, I see some folks here who probably have first-line experience, and they're nodding their head. So again, so these are very important. Mortality prediction for triage, it's disease-dependent. Sometimes we know the course of the disease. We know that pneumonia is fixable. So you have somebody with end-stage lung disease, but they're going to have a pneumonia, intubate them for a little while, you use a short-acting sedative, and you try to wean them as fast as you can, right, Sean? And let's extubate them before 5 in the morning, because that's the way we do it around here. But the fact is sometimes we know that people have had a stroke, and it's going to be really hard for them to get off the ventilator without a tracheostomy and a PEG tube and prolonged recovery. So again, the disease will often determine where the road leads. So when you talk about SARS, okay, these folks are frequently developing organizing pneumonias and pulmonary fibrosis. If you look at the data about ARDS, we won't be doing that a lot, but we're going to talk a lot about ARDS coming up. These situations are better understood now that we realize that many of these folks are chronically oxygen dependent, and they are frequently never go back to their prior level of functioning, even under some of the best of circumstances in the past, based on different but similar disease patterns. And so we have disease independent, once again, talking about critical care competing for resources. So again, so we look at outcome, and when we look at outcome, we say, well, you know, outcome, some will die even with ICU intervention. So again, you probably do not want to put those people into a triage situation. You know, if they can get by and they have basic medical issues or whatever, palliation, you move them into that kind of category and you triage them there. They will die without ICU intervention, but some will survive in the ICU. That's correct. Bring them into the ICU. Okay, again, will survive ICU without intervention. Do not put them in the ICU. This is what we will talk about in a little bit about is basically the notion of over-triaging patients. Patients who don't need to be in the ICU, but you bring them there anyway because you're worried about them. Okay? When you have infinite resources, it's great. Okay? I do that all the time. Kristen's probably smiling under her mask. I tend to over-triage when situations are warranted. But again, you know, it's a very different scenario. So under-triage and over-triage are both ideas of mistriage. Okay? There are ways of looking at mistriage. It's a misdiagnosis, if you wish. If you underestimate the urgency of their severity, they go to the floor and they crash. Okay, and then they should have been with you because you might have been able to intervene early and prevent them from crashing, and they would have done better if they hadn't crashed. And I'll talk about multiple organ failure in a little bit, and this is that typical scenario. Somebody goes to the floor, then shock. The longer you're in shock, the more likely it is you will die. So get them out of shock fast. If you're sitting on the floor and they're in shock, it's a bad thing. So that's under triage. Over triage is you're unintentionally overestimating the urgency or the needs. Okay. So over-triage is once again associated with increased ICU mortality. Why is that? Because you're depleting resources from other people. You're channeling things. Your ICU statistics, if you wish, are going to look bad because you are depleting resources from other people. You're spending a lot of time at the bedside with someone who's breathing on their own, is very demanding, and by the way, they're taking time away because a nurse can't be with the other patient who's actually starting to crash and they can't recognize it because they're spending too much time with this patient, okay? That's why mortality increases. not because the patients themselves are going to die, but because the ICU is going to be poorly managed. So you've got people in there who don't need it, but use a lot of time and use a lot of effort. So again, come up with a triage scheme. Inclusion for triage, for ICU access. Okay, need for mechanical ventilation. If they don't, routine medical interventions. If they do, you have to ask, are they meeting certain exclusion criteria? If you have somebody coming in with COVID and they just got burned, and we don't have a burn unit across town is not going to take them, well, maybe that patient might not make it anyway, right? Unwitnessed cardiac arrest. We used to bring these folks in, therapeutic hypothermia them for 2-3 days, try to wake them up, do seizures and look for the signs. But maybe they are not going to get better anyway. Severe dementia, metastatic malignancy, end-stage lung disease, greater than 85 years old, and this number might start dropping soon, okay? So again, if it's yes, then we start to move into palliative care. If it's no, then we try to move them into the ICU and start to work on them. This is a triage scheme. So you start to look, and usually it's color-coded, okay? I don't know, every place does it differently. Different countries do it differently. I think that, this is, don't memorize the colors. Just think about the fact that, green might be no significant organ failure. These folks are moving out. They're green lighted right out, okay? The other folks are red, okay? They are very high, okay? They're very high. And then you have here, these folks here that are blue, okay? They're blue on arrival. They're actually going to not make it anyway, so you move them directly into palliative care, okay? So just different ways of thinking about these things. I don't know what kind of color schemes we are using yet, but at some point we'll have to decide. So let's go back to our original question. So you had 3 patients. One was a single mother of 2. The second was an 82-year-old who had lots of problems, but he was really well connected. And then you had an 18-year-old with a drug abuse history. So how do we decide who gets the ventilator? Well, we get more information. Okay, so here's her information. So she's female, 2 females, 1 male. This one needs a ventilator. This one here is going to require high-dose norepinephrine. This one needs a ventilator. This one's in septic shock, is going to do okay on dopamine alone, okay? Comorbidities, turns out the mother doesn't really have any. This one has a lot, is on home oxygen, and this one here is a drug abuser. And then this one here is basically respiratory failure, acute respiratory distress, septic shock, and oliguric renal failure. So she's already down the road. It's that information we didn't have yet, okay? So the thing is, we have respiratory failure only and septic shock only. So we look at the SOFA score, as Dr. Vernon Carr suggested, we look at a scoring system, and we look at this and we say, well, this one here, wow, the mother, she's not doing well. It's got a SOFA score of 12, okay? Then this one here has a SOFA score of 4 based on their active morbidities. And then this one here actually looks like it's going to be the 82-year-old who's going to get the ventilator based on the SOFA score. Now, this may not be intuitive, but this is what happens if you use a SOFA score, if you use a scoring system. If you go to the bedside, your competing intellectual evaluation of this patient based on your knowledge, your experience, and your training are going to be such that you may actually, say, I don't care what the SOFA score says, this ain't going to work. It's got to be someone else, okay? So once again, you've got to be very careful when you set your criteria for developing a way of, triaging people. So when you talk about triage, you better have a standardized operating process. You got to know ahead of time what you're going to choose as your criteria and to ensure fairness. Okay, fairness is so important. And transparency. Believe me, whatever decisions we make at some point down the road, someone is going to look for an after-event review, okay, or after-action review to determine what happened under these circumstances, and there will be a public look back. So make sure that everything is transparent, make sure that everything is fair and is objective and is unbiased, as like many of the folks volunteered from the audience. These are all so important when we talk about criteria for triage, because it's not so much that we're afraid of what they're going to say. We shouldn't be afraid of what people will say afterwards. We should be able to stand and justify the decisions we made, okay? And that's very different from being afraid of what they're going to think, okay? We need to justify the right things, all right? So there are people who are crazy enough to think they can change the world, and then there's those who do. So again, this is where I put Dr. Herman in, but he's not here, and in the interest of moving along, I will. So he's going to talk about burnout and moral distress. I'm going to talk a little bit about PPE and biocontainment. So again, you are the most valuable resources. We talk about resources. People here are the most valuable resources. People are the most valuable resources. Trained personnel are the value that this institution brings to this event. Okay, this is so important. You got to take care of yourself. Yes, ma'am.
So before you move on to this next question,
Yeah.
about what you were just saying about the score and justifying it, being able to look back and justify your action. Are you going to address how we're going to document that in any way? So how would we document the choice that we made without HIPAA violating? I have 3 patients, you know, this is the choice I made based on this score. Is that something you document in the chart?
I would say I have an opinion. Okay, so I have an opinion about everything. It's like, but what happens is, so far my frontal lobe still works, and most of the time I don't say what's on my mind, but sometimes I do. And the fact is, this is going to be a decision to be made by somebody in legal. It's not going to be a decision made by me. So again, yes, you are right. There will need to be a way to document this for the after action review. When the look back happens and people say, why did you do what you did? So the thing is, until now, when we had somebody leave the ICU and we needed the bed, we just sent the patient. Having known what I know is that no ICU provider has ever been successfully sued for sending a patient out of the ICU for what the family said was premature. Okay? So nobody has ever done that before. It's never happened. People have tried. Okay, there have been a lot of lawsuits. Nobody's ever been successfully sued for that. So the fact is we never had to document this. I never had to say, oh, gee whiz, I had somebody coming in who was sicker. But you're right. Somebody's going to have to document and somebody's going to have to tell you how to do it, and it won't be me. Okay? Good point, though. Very good point. Yes, sir. That's one way of doing it. I will leave it to the ethicists in the hospital. I will leave it to the ethics committee. I'll leave it to the documenters. I'll leave it to risk management, and I'll leave it to legal. Yes, sir. That's an easy one. You're absolutely right. And that's an easy one, relatively speaking. Okay, I mean, there's no easy ones, okay, but I'm going to try my best here. So the answer here is that you're a team. I think teams debrief. When bad things happen, teams talk about it. And it has to be a non-punitive, non-judgmental debrief. And that's how things work. And so if in my ICU, what I do is, and folks will tell you, everybody gets a say as to what we're going to do. If someone's going to be extubated, simple decision. I got respiratory buying in, I got the bedside nurse buying in, I got my PAs buying in, and sometimes I come in and I want this patient extubated, but you know what, the respiratory therapist said, I had to suction a mucus plug out of him at 3 o'clock in the morning, he almost died. Oh, wow, gee whiz, okay, sure I thought about that, I didn't know that, right? Everybody has some information, so you've got to make it so that everybody feels comfortable with the decision. And you have to make it so that people feel free to volunteer what they know and what they feel. And you're absolutely right, okay? These situations usually become issues, sometimes internally for the team. But I think when we're talking about large-scale stuff like this, it may become that it'll be a social issue. You know, if newspapers get hold of it, okay? Something like that, right? I think you have to still have that process in place to be able to justify the decision-making you use. And again, so that's what I know. And that's, that's basically, it has to be transparent, it has to be fair, and you have to use some kind of objective criteria. What you decide to use is going to be individual, okay? And that's important. Good points, though. Yes, ma'am. So again, I think the very good points. The first point was that nobody will ever feel comfortable with these decisions. And that's why Dr. Herman's coming, okay, to help. And the other thing is that you're absolutely right that, again, this has to be multidisciplinary. It has to involve a lot of folks. People know the patient. And again, how you put these committees together traditionally has been very broad. Many times, okay, I mean, I have absolutely nothing to do with the way the hospital is structuring this right now. So I don't even know what they're doing, okay? But the fact is that usually you have a team, multidisciplinary team of providers. Then you have someone who has ethics background, someone who might be the chair of the ethics committee. Usually you get an attorney. And usually you have somebody who's a knowledgeable layperson, okay? So these folks get together and they build a committee, okay? And you have this multidisciplinary input. So it's not specifically biased. That is how, I hate to use the word best practice, but that's kind of a best practice. Okay. Good points all around, okay? So good. So very fast, PPE, biocontainment, maybe I can get through this. There's not a lot on this. I'm going to talk very quickly about this because I think everybody here has learned a little bit about it. And I think folks, there's some ideas here that I want to share. So it's probably only about half a dozen slides at that. Okay, so maybe by the time Dr. Herman gets here, we'll be done. So you're the most valuable resource. Remember the unknown knowns. Those are the things that are going to kill us that we don't know about, right? So the thing is, you got to think about the things you don't know. In my work in the ICU, my biggest worry every single day is that I miss something. I'm sure everybody here feels the same way, right? So it's the things you don't know that you feel worst about. Okay, that's very, very important. So remember, the virus is invisible, it lives on surfaces, it's spread very, very quickly, and it can be spread by asymptomatic individuals, and testing has been delayed. So, we want to think about a couple of things. There's personal protection. Okay, we talk about personal protection. Again, I put these slides together over the weekend, so, I don't know. I mean, probably as comprehensive as I can be, but probably not totally comprehensive. Structural, systemic, and personal, okay? We think about personal. This is what we think about PPE, okay? When we talk about PPE, remember, there's also the weakest link. It's the other person who came out of the room that went over and touched the charge phone, then spread it onto the regular phone and to the computer terminal by not adhering to PPE. We used to call that the weakest link, okay? And it was a great show, right? But the fact is, there can be weakest links in the system. We have to be careful about that because you have to be a system, you have to be a team, you have to work together on this. Again, okay, there's also systemic things. Anybody know about Meshed Hospital? I sometimes speak to the nurses on this. We talk a little bit. So I had to find the slide. It was really hard. So the thing is, Meshed Hospital was a hospital in Germany. So in 1972, Meshed Hospital had a patient with smallpox. So they brought the patient in with smallpox, and they put him in a room. It turned out it was a negative pressure room. That's good. They did the right thing. It turned out that the negative pressure was actually venting inside the hospital. So everybody on the floor got exposed to smallpox. So again, when we talk about PPE, there's structural system, okay, very, very important. And then there is the weakest link, okay, it's sort of the process. And then we have the issue of personal PPE. So I promised Dr. Herman that I would let him go. I don't know if he has slides or not, but this is where we worked him in, and we will pick up as we go. Okay. Dr. Herman, awesome. Don't pull out the one that's in there. I think you have to go down here. Let me get it for you.
Can I do this one?
Yep. So what I want you to do is maybe escape out of here, minimize that, bring that down here, and you are this one probably?
No, I'm the other one.
Oh,
This age. I'll do it.
okay.
So, can everyone hear me? I'm here to talk about something that I'm not sure that many of you are excited to talk about. Maybe one of the harder things that we're going to be dealing with, which is communication. Thanks. Communicating with patients in a setting of limited resources for COVID patients, and also anyone else in the hospital, really. So the challenge here is we have to have very difficult conversations, and we actually need to have them earlier rather than later. And many of you will be taking care of patients or having to deal with families. It's probably the part that's the thing that we fear the most. It's hard to pick up the phone and call someone and have these discussions, but we're really going to be forced to do it. And I think the way to do this is actually introduce the topics early in our discussions with the patients when they can still speak for themselves, to get a sense about who they are, as well as when they get worse or that things are escalating, to be able to talk with family. So this is a slide set that literally came out yesterday from the university. I actually like it because it gives good structure and how to engage in conversations that are directed. There are a lot of materials out there. I'll try to show you some of them later on. So there are personal communication skills. We're trying to get this out to people so we can use a common language when we engage patients and families in their care. So this is called ACT, Advanced Communication Training. They tagged on a little thing called COVID-19, but you can do this for any serious illness. So being proactive is probably the most important thing, and they use this model MVP. It's not the insurance. It is called defining the medical situation, exploring values, and then making a plan. And there are pieces to this. It's a three-step process. The first thing you have to do when you call someone is you have to be pretty clear about what you're discussing. Okay? What's the new diagnosis? What do you think the prognosis is? What the treatment options are? Are there limited resources? I hope we never get to the place where we have limited resources. But even if we have plenty of resource, these are the discussions that we need to have. Once you define the medical situation, you explore their values. What are their preferences, hopes, and worries? And I know that we fear, well, they're just going to say they want to live forever, or they want to live. And that's true. Most people will say that. And I would say this is not about living. It's about how they want to live. What are their things that make them who they are? Do they like to go fishing? What are the things that make someone who they are? And if we have limited resources, what are the things that should come into play, or what would be important to them if we can't get them a ventilator, for example? Or they don't want to escalate, what can we do for them? And then you have to define a plan. Treatment choices or lack of choices, code status, for example. And this is an iterative process. If you engage someone and they don't understand their prognosis or they don't understand the disease, you're going to have to go back and make sure they understand the medical situation before you can actually explore their values about what's going on. And so there are three communication skills that help with this. And they're the 3 E's. Empower. So the first thing you have to do is ask what they know and calibrate and listen to them. This is not going in and telling them everything up front, okay? Because that feels like a one-way communication, and they feel like they don't have a say in what's going on. So you really need to ask, hey, this COVID thing is pretty scary. We're concerned about it, and I want to talk about that. Is that okay? So you're inviting them to offer you information that empowers a patient and family to feel engaged in their own care. You need to then consider what they say and try to educate or bring them up to a level where you're aligned with what's going on. Let me fill in the gaps for you with your condition, or tell me what you know, and then I'll try to fill in the gaps and make sure that we're on the same page before we move forward. I am doing this relatively fast because I want to be respectful of the time. I'm happy to take calls or questions later, offline, whatever. Be explicit, okay? The other important thing when we talk about this is not to use euphemisms. Be precise in our language and concise. We're very worried that you have COVID, and this could be a serious, life-threatening, or even an illness that could cause death. And you have to be pretty explicit about this. They're worried about it already. I guarantee you they're already thinking about, do I have the COVID or not? But I think we need to be very explicit when we're describing something, the prognosis, progression, or concerns about mortality, to be pretty explicit. And the last thing is we need to be able to empathize. And I would expect emotion. You have to be prepared for that. And you have to be able to respond. And you don't respond by minimizing it, saying it'll be okay or everything will be all right. You need to respond by using empathic statements like, I hear that you're really upset about this. You sound really frustrated. You seem angry. This seems overwhelming. It sounds like you're feeling that there's nothing we can do. Rather than say, don't worry about it, it's going to be all right, that's a minimizing tactic. You want to actually validate what they're saying. We empathize by validating what their feelings are, and that allows them also to feel like they're being heard and listened to and a part of the conversation. So this gets a little bit too complicated for what I want to get into here, but these two things are working in process. You use some empowerment statements, explicit statements, and empathizing statements in each one of these stages. And just to give you an example for some communication skills tips, here's one. This is a yellow statement, empower. COVID's on many people's mind, and I think it's important to have a discussion with you about that. Is that okay? Again, you invite them to be a part of the conversation. What have you been thinking about COVID? Or what do you think about whatever serious illness or condition you're in? Tell me what you know. Again, you're asking first and then calibrating with them to make sure they have they understand the medical situation. You'll see that the box sort of lines up with the medical situation. That's what we're working on here. I'm hopeful you won't get COVID, or I'm hopeful that you'll recover, and I'm afraid that you could have complications or it could get worse, or you have multiple comorbid conditions, and that makes your risk of death or dying high. So green statement is an empathizing statement. I'm hopeful that we can help and get you through this. I'm afraid that, and then be explicit and precise. If you get COVID, this could be serious life-threatening illness. I'd like to explore your wishes. If you do get COVID, or if things are getting worse, if you have any acute illness or disease progression, is that okay? Again, you're empowering them to participate in the conversation and offer their thoughts and values. Then if they invite, most of the time they will invite you, you say, acknowledge that this is a hard topic to talk about. This can be scary. Talking about this up front will help us honor your family, your wishes and your family's wishes. I know everyone's thinking, I don't have a lot of time to do this. We need to be able to spend a little bit of time before someone's intubated, if we can, to have these conversations. It will save a lot of headache and potentially lives down the road if we have scarce resource. Because there are certain people out there that do not want escalation of care. And half the battle is that we don't ask them about that because we're afraid. It's hard. So when we move on to the value section, we talk about, given your medical situation, that you have multiple comorbidities and you could get seriously ill, or you also have other organs that are failing. What matters most to you if you get seriously ill? And you might hear, well, I want to live. What do you want to live for? Would be a question. Tell me more about that. Is it being independent? What kind of work do you do? Get to know the patient a little bit. If I hear you right, your values are, this is now being explicit, you like your independence, you like to fish, you like to drive your truck, you like to name whatever it is that they're interested in, okay? That might mean that, excuse me, sorry. That might mean they value quality of life. Most of the time, people will make statements about quality of life as being of primary importance. And that's important to acknowledge and reflect back. It sounds like you'd like to live as long as possible. However, you have a certain idea of what quality of life is, and that you want that to be respected. And that's what you're hoping for. Can we explore what you would want if you were so ill that you needed a ventilator, or name the next thing, dialysis, these other things? And it's important to identify, if you can, an alternate or a proxy if they haven't already. Again, that's empowering, giving them the option to tell you something, to be a part of the conversation. And then you have to provide an empathizing statement or reflect back, I appreciate your courage in discussing this painful possibility or these issues. When we get to the plan stage, again, empowering. Now that I understand your values, I'd like to offer a recommendation. So this is where I think as a team, we have to discuss and we have to have an idea of what we want to say. What are we offering? And granted, in a situation where we have unlimited resources, that's one thing. In one where we don't, that's a very different conversation. But for the most part, if someone values quality of life, it's going to be, we're going to continue to offer everything we're offering. However, what I'm hearing is you value quality of life, and if we got to a place where we couldn't protect that, or we would be causing more suffering than benefit, you wouldn't want, you would want us to respect that and make you comfortable. Given what you told me, I recommend. Does this make sense? What do you think? So oftentimes offering something out there saying, this is what we would recommend. You have 3 organs that have partial failure at baseline and you have COVID and your lungs are failing. We don't feel if you got worse and got on the ventilator, it's likely that you would not survive. You can make a recommendation. I recommend that we don't put you on the ventilator. Now, that comes back to the individual provider and team that's taking care of a patient, but you certainly should give them the option of what that you could do, from we support in place, we escalate some, we escalate full press, okay? Now that's clear, let's complete some forms. If you get to a place where you can complete a MOLS form, great. If you can complete a healthcare proxy form, great. They may already have a healthcare proxy. I would confirm who that person is. And then I think you need to thank them for participating in the conversation. This is a very hard thing to do. You've done a great job in taking care of yourself and your family, and this will help us take care of you and respect your wishes. So there are scenarios, and so there's a scenario card, and we're going to be publishing or putting out a palliative care toolkit. It has to go through the central command and stuff, but this will be coming, I hope, to be able to access some of this information. There is the conventional scenario where you're just doing proactive advanced care planning. I think that's important for all our patients. From when they come in first thing, it's an easy thing to mention. COVID's on everyone's minds. What do you think about this? It's important to discuss this topic. What are you thinking? And go through the process. At least identify a healthcare proxy. Identify maybe their hobbies or the things that they really like, because those are things that you can use to come back to family if you're in a difficult situation. So there's also contingency scenarios. I'm not going to spend a lot of time. I think the most important is having these discussions up front. There is we'll walk through just one scenario where it's more of a crisis scenario. I think one of the most important things we're going to need to mention, and we may even need to mention now, just to put it out there, and I think I would request that the administration also do this, although we'll see if the community makes an announcement. I need to tell you that we're in a crisis. And there may not be enough ventilators or X, Y, Z, whatever resource you want to say, for everyone who would otherwise get one. I'm not saying that they're not going to get one. I think we need to acknowledge that we could very well be in a crisis situation. So once this notches up a little bit, or we're starting to feel the press where we may not have that flexibility of just to throw on another vent, we need to be announcing to patients and families up front that we may be in a situation where we don't have resources, and to be explicit about it. We may not have ventilators. So there is a website, and I'm going to show you something else here in a minute, but I just want to go through one scenario or two. This is tough. This is hard work. Communication with families is loaded, is emotionally loaded. Sometimes I think I would like to be in the thick of it with Dr. Zalatos and throwing in lines and doing that stuff, because I can just focus and do that. But when we have to engage someone else and the emotional context of it, it's tough. So you guys are taking on a heavy lift, and I really appreciate that. Take care of yourselves, take care of your loved ones, and take care of your colleagues, okay? I'm going to skip through this. say we're in sort of some actual ventilator limit setting and we're talking to a patient, but they're not quite on the ventilator yet. First thing you do is seek mutual understanding. So this is just a sample discussion, okay? I know it's not fully representative. I'm afraid I have some more difficult news to share with you. Inviting. I'm going to tell you something. Are you prepared to hear it? What could be worse than this, right? This is what you're going to hear. How could you be doing this? Be explicit. The COVID crisis has depleted ICU beds, vents, et cetera, whatever it is that we don't have. There just aren't enough to go around with those who need them. And this is what you're going to see, right? You're going to get responses like this. You're rationing, you're playing God, you can't do that. The goal here is not to get defensive. If you get defensive, you've lost the war. You need to be empathetic. I can see this is hard to hear. I wish we had more. If there's ever a line that you need to come back to, say, I hear you, and this sucks, and I wish we had more. Because once you get into the negotiation of, well, we really don't, and we're not rationing, and we're not playing God, they're going to say, oh, yes, you are, right? That's just a vein for an argument. So step back from that. Don't engage that and feel what they're feeling, which is, this sucks, right? If this is really happening, this sucks. You just have to say that. And they might go through that a couple times. You just come back, I hear that this is really frustrating, this is upsetting, this really sucks. I wish I could change things. All right? Oftentimes you can move through that phase, and once you've leveled, you've calibrated with what's going on, this is a horrible situation, right? You're empowering, given what you've heard and what you're thinking, what are you worried about? What are your hopes? I really don't want to die, but I really don't want to die. I don't want to suffocate, right? I don't want to be short of breath. Empathize. I hear you, and we'll try to treat your symptoms. If you got sicker, what would you hope for in this awful situation? You're empowering, empathizing, and empowering. I want to be able to say goodbye to my wife. You'll often get things like, I want to make sure my family's okay. I want to see them. That might be a difficult one. Be explicit. I understand the most important things for you are to breathe easy, and when the times come, to say goodbye to your wife. Plan. Now that I understand your values, and we've offered our situation, we have no vents, or we're almost have no vents, or whatever the situation is, I'd like to offer you a recommendation. Is that okay? Again, invite them to be a part of it, empower them. They may not agree with you completely, but okay, but it sounds like I die no matter what I do. What a choice. And be explicit. Yes, this is a tough, forced choice for sure. Given what you told me, I recommend that we keep you comfortable. We don't put you on the ventilator, that we use medicines, that we see if we can get your wife to come in. This is really a terrible place to be, and I promise that we are here to take care of you and support you and make sure that you don't suffer. I'm not sure how believable that is to you, but I think you need to be prepared to face those emotions. The best way to respond is not get defensive, but merely acknowledge and hear them. I hear what you're saying. This really sucks. There is a crisis scenario if you're talking with the surrogate. You know, it's a similar sort of setting, except you're over the phone. I have some serious news. Are you a place where you can talk, empower? Be explicit. The ventilator has not helped, and so this is where you're actually having to take someone off a ventilator, right? Theoretically, I hope. The guidelines require that we stop the ventilator. Oh no, you can't just let them die. Empathize. I cannot imagine. Again, it's not, we don't want him to die either. It's not the sort of minimizing or engaging and getting defensive about it. It is, I can't imagine how painful it is to hear what we're saying. This is unbelievable. You're doing this because he's old, black, poor. Name your vulnerable class, okay? And you're going to hear that. You have to acknowledge, it sounds like you feel like we're doing this. This is a truly terrible thing. I can see how it might seem like that. And they'll continue to probably ramble on about that. Not ramble, but be angry about it truly, and as they probably should be. And you have to come back with something solid, like we are using guidelines developed by experts in ethics and healthcare to make extremely difficult decisions about who can get these limited resources. That's determined really by a community-wide ethics group that is ongoing, is meeting ongoing right now and using a specific scoring rationale. So you're going to play God. I really hear you. I wish things were different. That's a good line to remember. Given things as they are, what would your dad say now? What would be important to him? Exploring values and empowering them to participate. He'd be pissed off, but he said, let me go and don't make a fuss. Sounds like someone I would have really liked to have known. Complimenting and acknowledging these difficult engagements and valuing our patients for people and humans who live and are our neighbors is really important. And that might give some balm to these patients and families. Now that I understand your father's values, I'd like to offer the following. We're going to make him comfortable. We're going to make sure he doesn't suffer. And remove the ventilator. Can I see him? Hold his hand. So those are just some of the things. I'm going to exit out of this. See if I can. I just want to show you a couple other things here. There is, we are developing a toolkit. I just wanted to show you, this is a compilation of things from different areas. These resources, I'm not sure if I can zoom this up. If you want to take a picture, are great resources if you want more stuff on communication. Okay, again, this will be posted eventually, but there are great resources here. The VITALtalk is actually a great one. Not sure if it'll let me click into it, but this also gives you sort of one-liners if you want to take a look at. Let's see if they. So there's a whole bunch of screening, preferencing, triaging. I'm sorry, I don't want to take up too much more time. So there's other resources out there. You can always reach us. There is a role for for palliative care. Generally, if you're having challenges with communication, we're here to help not only with communication at times, but also with symptom management. There's some symptom management tools contained in here. There's not enough of us to go around. You're not going to have necessarily a palliative care doc at your side everywhere you go. We would love to do that. We just know there's not the manpower to do it. We are here as a resource, and we'll field any questions. I'll just take questions. Any questions? Yes?
Do you have a handout? Is there a way that you can send your slides to me so she can
Sure. Yep. Yes, sir. Yeah. This is a sort of a press everywhere. Everyone's talking about this. How do we get people to the bedside? There's some rules that I think they're finalizing about end-of-life visits, and even for those who are COVID or being taken off, depending on the visitor status. I don't have the final recs of what they're going to be putting out, but we are advocating to try to see if they're within a certain time radius and a certain time that we could get them to the bedside. If not, then potentially using extender or tech to get in the room. I know that the palliative care team, we've ordered 3 iPads specifically for this purpose to try to get into rooms. I will tell you, I'm using my phone in a baggie and changing out stuff at times, or double bagging and doing Zoom meetings so they can at least see what's happening with their loved one. This is really tough. It takes a lot of time. I'm not sure that we're going to have all that time, but I think those are good questions. Trying, yes. verbal code status. So code status is can be a verbal. There's nothing that requires that a MOLS be signed. Okay, and actually, e-MOLS would say that you really don't. You just need it to be witnessed. So that's one of the challenges if you're talking with someone. You have to make sure that at least there's two people on the line with you. It doesn't necessarily have to be healthcare. I think it might be good to have someone, but if it's you and there's the decision maker and another family member, and you're all agreeing, and you say DNR, you can write that down and write both their names as the person who's agreeing, the other person who is witness, and you are the witness if you can sign that MOLS form, okay? The doctor can be the second witness if they actually did it. I would assume that the nurse practitioner could be the witness if you're the actual person doing the discussion. Good question. Other questions? Yes, sir.
Have you looked at the population of chronic vent patients who are, for example, working they're getting very aggressive care that perhaps their own families never would have chosen for them? Is that something anybody is into, or?
Yeah. So that's a very good question. The question is, there are vulnerable patients, DDSO, people who may be on vents, chronic long-term vents. The allocation strategies, I would just tell you, is stay out of the hospital if you're on a chronic vent. If you come to the hospital and you're a chronic vent patient and we're in allocation mode, it's quite likely that they'd be allocated off. And it wouldn't be because they are DDSO, it's because their scores and their likelihood of short-term survival or a return to function is very or extremely low. That's for anyone. So if you're in a nursing home and on a vent somewhere, stay there. Don't come to the hospital, because if we're on allocation, you could get your vent allocated away. But it's not going to be based on age, race, disability.
Nobody's going proactively for those.
No. No. And I think that you wouldn't be able to do that because of New York State law. Other questions? Any other questions? Otherwise, please feel free to reach out to me.
10-minute break.